Assalamu alaikum. It gives me a great pleasure to introduce next speaker, which is my dear colleague, and I think he is famous enough that he should be introducing me. Dr. Imran Tailor is a consultant hematologist at our Comprehensive Cancer Center in Department of Adult Hematology. After obtaining his MD from India, he has got fellowships from Royal College of Physicians and Royal College of Pathologists in UK. He is very active in clinical care, teaching and research. Please welcome my dear colleague.
A very good afternoon to all. Bismillah ar-Rahman ar-Rahim. Salatu wassalam al-Mursaleen. Allahumma salli ala Muhammad. And very kind words from my dear colleague, Dr. Zaidi. Not only my colleague, my teacher as well. And I welcome you all to the second annual symposium on VTE Prophylaxis. And I thank Dr.sheef and the organizing team for inviting me to talk on VTE prophylaxis in cancer. In the next 15 minutes or so, I'll try to summarize as much as I can on this particular aspect. And I can relate to this topic very well, being a hematologist at the same time an oncologist. So just before I start, a little bit about history. This gentleman, Armand Trousseau, we owe a lot to him for whatever we know on VTE in cancer. So he was the first to associate thrombosis and malignancy. He was the first to suggest screening for malignancy in recurrent and idiopathic thromboembolic disease, and first to suggest that the pathophysiology was not just mechanical obstruction, but a change in the character of the coagulation system itself. So he was the first to suggest as well the association may be integral to the cancer growth itself. He died in the year 1867, and sometime in June, he wrote a letter to his friend in January. His name was Peter. Peter, I am lost. The phlebitis that has just appeared tonight leaves me no doubt about the nature of my illness. And he died 6 months later of gastric cancer. So it was idiopathic unprovoked DVT, which later on manifested gastric cancer and was responsible for his death. So cancer is an independent and major risk factor for VTE. Cancer increases VTE by several fold. Inpatients are the highest risk. Incidence ranges from 4 to 20%, and recurrence is 3 times higher among cancer patients. And VTE rates are underrepresented burden. Autopsy in some studies, the rates are as high as 50%. And it is the second most common cause of death among ambulatory cancer patients. So why should we care? This is the reason we care for VTE in cancer. 47-fold increased risk of mortality from VTE, and as I told, second leading cause of death in cancer patients. Here you can see 2/3 of the patient die of cancer itself, but thromboembolism accounts for 9%, tying with infection. And again, why should we care? Because cancer patients represent about 18% of all DVT and PE cases. If we include superficial venous thrombosis, it goes beyond 23%. And again, incidence of VTE increases with cancer therapy. So all patients with time, 28% increase, but those on chemotherapy, the increase is up to 47%, and partly because of chemotherapy drugs itself. So what is the effect of VTE on long-term prognosis? If you look at this graph here, the probability of death is higher if the patient with cancer has DVT or PE. Again, 1-year survival is inferior if he were to be diagnosed with DVT or PE at cancer diagnosis. Again, as I told, the recurrence rates are higher in patients with cancer, as you can see in the graph, 6.8% versus 20%. So why do patients with cancer get blood clots? One is tumor infiltration into the vessels, vessel obstruction, immobility, central venous catheters, post-surgery, medications, like some of the drugs in cancer, we use tamoxifen, raloxifene, and also immunomodulatory like thalidomide, lenalidomide, pomalidomide that we use in myeloma, and chemotherapy itself, not forgetting dexamethasone, the high-dose steroids. So this is a simple cartoon depicting why patients with cancer are at high risk for blood clots. The tumor cells secrete a lot of inflammatory cytokines, tumor necrosis factor alpha, interleukin-1, and various growth factors such as VEGF. And also the tumor cells produce tissue factor, which are procoagulant and initiate thrombosis. And platelets are overactivated, so they also promote thrombosis. And presence of catheters, central venous catheters, also aid in thrombogenesis. And certain chemotherapeutic drugs, as I mentioned, immunomodulatory analogs, which are anti-angiogenesis in nature, also promote thrombosis. So, this study says VTE prevention or prophylaxis is low. This is an endorsed study, the multinational cross-sectional survey around in 32 countries, more than 300 centers, over 60,000 patients. So 51% of the patients, all medical and surgical patients, were at risk for VTE. But VTE prophylaxis underused, only 58% of the surgical patients received it, medical patients only 39%. So 37% of medical patients with active malignancy received VTE prophylaxis. So it is underutilized and underrepresented. So can we predict VTE? So these are some of the factors that you can look at that promote VTE in patients with cancer. Patient-related, the black patients ethnically are more prone for thrombosis. Comorbidities such as diabetes, hypertension, heart failure, obesity, as Dr. Abu Khatir just so eloquently talked about, poor performance status, and increasing age. And what about the cancer, advanced stage, histology, and the highest risk is in the first 3 months. Treatment-related, as I mentioned just now, and also erythropoiesis stimulating agents that we are using more and more commonly these days can also promote thrombosis. Certain biochemical markers, high white cell count and high platelet count and low hemoglobin also aid in thrombosis. So this was a VTE risk score that has been prospectively studied and validated by Alok Khurana from Cleveland Clinic. He developed it using prospective observational study of 2,700 patients, ambulatory cancer patients receiving at least 4 cycles of chemotherapy, validated in greater than 10,000 patients. So the scoring is, if you are very high-risk cancer, such as stomach or pancreas, they get a score of 2. Other cancers get 1, like lung cancer, lymphoma, gynecological or GU cancer, excluding prostate, high platelet count, anemia, high white cell count, and high BMI. So anybody who has a score of more than 3, his risk of VTE is nearly 7%, where a score of 0 is only 0.5%. So here you can see the low risk incidence of VTE. So in the high risk group, the incidence of VTE is almost 7%. So again, these are the different trials, and you probably would hear about these trials again and again. MEDNOX trial, PREVENT trial, Artemis, showing the effectiveness of thromboprophylaxis in hospitalized medical patient, how they decrease the VTE risk significantly from 14% to 5% in MEDNOX trial, and so on in PREVENT and Artemis trial. Again, this is a study from some of the cancer patients. PROTECT study was locally advanced or metastatic solid tumor and myeloma, and JAMA study, CONCO 004 and FRAGM study was both for pancreatic cancers. Again, uses of prophylaxis reduce VTE. So coming to, there are so many guidelines that you can find for VTE. You have American College of Chest Physician, American Society of Clinical Oncology, 2013, updated in 2015, and NCCN, which also came in 2016. And you have Canadian guidelines, you have British guidelines, you have Italian guidelines, Scottish guidelines, so many guidelines. Pretty much similar in their recommendations. So coming to some practical points. So do we need to prophylax patients who are ambulatory cancer patients? So this is a Cochrane review of 21 randomized controlled trials involving more than 9,000 patients showed prophylaxis with warfarin or enoxaparin in ambulatory cancer patients. It reduced VTE by 40%. And this is the same study in numbers. You can see here, placebo was much higher when compared to the patients who received prophylaxis. 44 per 1,000 to 27 here, 11 versus 18, 8 versus 5, and so on. Again, multiple myeloma and venous thromboembolism. You can see uses of immunomodulatory analogs such as thalidomide, lenalidomide increases the risk of thrombosis by even 10%, up to 20% even, and high-dose dexamethasone also increases the risk of thrombosis. And certain other chemotherapeutic agents such as anthracyclines as high as 50%. So, should the cancer outpatients on chemo receive VTE prophylaxis? No, not all patients should receive VTE prophylaxis. Selected patients with high-risk factors, as I discussed, those with Corona score more than 3, after discussing with the patients, should be considered for venous thromboprophylaxis. And some patients, such as myeloma patients who are on thalidomide, lenalidomide, or pomalidomide, should receive prophylaxis with aspirin or low molecular weight heparin. There is a paper by Palumbo group in JCO 2013 about the risk factors in myeloma. Those without risk factors just get aspirin, 0 to 1 risk factors. More than 1 would get low molecular weight heparin. Risk factors include diabetes, hypertension, immobility, previous VTE, obesity, high-dose steroids, and so on. So what about prophylaxis in hospitalized cancer patients? As I discussed just a while before, Mednox trial, how elegantly showed reduction in VTE in hospitalized cancer patients with low molecular weight heparin. There are 3 commonly used low molecular weight heparins, but there is no head-to-head comparison, so the choice is yours. And there is no cancer-specific phase 3 randomized control trial on VTE yet. So we get all the data from subgroup analysis from the major trials. And there is one study, Carrier et al. Showed superiority of fondaparinux or low molecular weight heparin versus placebo, but DVT prophylaxis is likely to be effective as cancer is associated with higher rate of VTE compared to general medical or surgical patients. So, should cancer in patients with acute medical illness receive prophylaxis? Yes, with or without risk factors, and this in ASCO guidelines, ESMO guidelines, even updated ASCO guidelines in 2015. And in cancer, like treatment, even for prophylaxis, low molecular weight heparin is the treatment of choice. So what about patients undergoing major surgery? Canby showed trial, 625 cancer surgery patients showed less VTE in the heparin arm compared to the placebo, 0.8% versus 4.6%, which was significant. Again, we have data from meta-analysis that decreases incidence of VTE. So there is no evidence for low-risk outpatient surgery, but one should take into account the duration of surgery. If it is more than 60 to 120 minutes, or site of surgery, such as arthroscopy or venous surgery, you should consider prophylaxing them even if they are minor outpatient surgeries. But what about major surgery? Major surgery that involves pelvic or major cancer surgeries more than 120 minutes. There is good evidence, and ASCO guidelines 2013, 15, ACCP, NCCN 2016 all recommend to use prolonged anticoagulation up to 4 weeks. So mechanical prophylaxis alone is not advisable unless there is a significant bleeding risk with anticoagulation. You can use both mechanical and pharmacologic, and any procedure at least 7 to 10 days one should use prophylaxis. but extended anticoagulation is recommended up to 4 weeks for patients undergoing major cancer or pelvic surgeries, especially those with high-risk features. So there is insufficient evidence to recommend for low-risk surgeries, as I mentioned before. So what is the preferred prophylactic therapy? Low molecular weight heparin is a preferred anticoagulant. As I told, there is no data comparing head-to-head of any of these heparins, and you all know the standard dose of these heparins. What about patients with CVC catheter? So there are 3 systematic reviews and meta-analysis failed to show that they lower incidence of symptomatic CVC-related thrombosis. So there is no evidence, even in updated ASCO guidelines, to prophylax these patients. And this is 1B recommendation. What about patients with renal insufficiency? So low molecular weight heparin tends to accumulate in patients with GFR less than 30 mils per minute. So one should be cautious. Tinzaparin has the highest average molecular weight, 6,000 Daltons. So, and it's less renally dependent for clearance and cleared by reticuloendothelial system. So one could use tinzaparin in patients with renal insufficiency when compared to enoxaparin or dalteparin. What about elderly patients? There is no evidence to make any specific recommendation, but one could use tinzaparin if there is low GFR. What about thrombocytopenia? And no trials have addressed this issue. And generally for clinical trials, thrombocytopenia is an exclusion criteria. But bleeding risk is negligible if the patients have platelets less than 50,000. So you could give routine anticoagulation if the platelets are more than 50,000. But if the patients have high risk factors and at high risk for thrombosis, even between 20,000 to 50,000, you could safely use thromboprophylaxis. And most, if you are not sure, you could talk to a hematologist or a thrombosis expert. ASCO guidelines recommends no prophylaxis below 50,000. So you can use thromboprophylaxis even in CNS malignancy at the discretion of treating physician. The Prognosie trial randomized 186 patients and found no difference between patients or between treatment arm or placebo, but there is a lot of positive data from prospective studies. However, evidence is limited. What about obese patients? As Dr.sheef mentioned, more than 30 BMI is an independent risk factor, is considered obese, and obesity itself is an independent risk factor. So there was a prospective comparison of 530 patients with BMI of more than 40. They showed factor 10A levels significantly higher in the 0.5 milligram of Clexane compared to 0.4 milligram or fixed dose 40 milligram. And there was no increase in bleeding. So one should use actual body weight rather than ideal body weight in patients who are obese. What about novel anticoagulants or DOACs, direct oral anticoagulants? So we have rivaroxaban, apixaban, edoxaban, or dabigatran. There is data from phase 3 trials for DVT prophylaxis from hip and knee replacement in medical setting, but data for cancer patients is lacking. And these trials use variable definition of cancer patients. Some of them were cancer survivors, and in most of these trials, these patients accounted for less than 5%. So there was a recent meta-analysis of 9 randomized controlled trials evaluating more than 2,000 patients, and they showed, in comparison to VKA, that like warfarin, low molecular heparin showed significant reduction in VTE, whereas directly DOACs did not show. Again, there was increase in bleeding from low molecular heparin, which was non-significant, but DOACs showed non-significant decrease in bleeding. So ongoing and planned studies would answer these questions. So currently DOACs are not recommended in the prophylactic setting. There is another talk on treatment of VTE in cancer tomorrow. They will talk more about this in this category. So what about overall survival? So there are, I will not go into too much details, but there are some meta-analysis, Cochrane reviews. They showed probably there is some survival benefit in patients with cancer with anticoagulation. However, major bleeding was higher, and most studies were 15 years or old, small subgroups, post hoc analysis, and primary endpoint was different. So the use of adjuvant anticoagulant therapy in patients with established VTE or unselected lower risk to prolong survival is not recommended. And it is in ASCO guidelines 2013 as well as 15. So monitoring routinely is not recommended, but in patients with renal insufficiency, you could check initially and periodically thereafter at the discretion of treating physician. So these are some absolute contraindications that you're all aware for anticoagulation, and some relative contraindications. And finally, patient-clinician communication is very important if you want to win this war against VTE and cancer. Patients with cancer are often unaware of VTE signs and symptoms and its association with malignancy, so one has to take time to educate patients. And patient education increases the likelihood of early intervention, and oncology team should take personal care in educating these patients, and ongoing communication, including history, physical exam, can facilitate awareness of VTE. Thank you very much for very patient listening. I'm happy to take any questions.